We're going to move on now. My colleague Wolfgang Gaertner from the university is going to come up and talk to us about total neoadjuvant therapy for rectal cancer, or full neo.
Thanks, Brett. Good morning. Thanks again for the invitation. We're going to go relatively quick through some of this because there's a lot of slides with data on it. I have no disclosures. So I would like to talk to you about the road that has led us to neoadjuvant therapy, or otherwise TNT, how I'm going to refer to it during the talk. The indications and outcomes of adjuvant and neoadjuvant chemotherapy for rectal cancer, and what the current status is and future directions of all the components of neoadjuvant therapy for rectal cancer. So what we've seen over the last 3 decades, improvements in rectal cancer, is first of all total mesorectal excision bill healed in the early 80s. Imaging, specifically the visualization of the circumferential resection margin via MR. Histopathologic assessment and grading of this that initially came from the UK and has done a pretty good job in the US and Canada and other parts of the world. Specifically neoadjuvant therapy, both components of chemotherapy and radiation, and most recently multidisciplinary care and techniques. I think it's well published that in the current guidelines that with stage 2 and 3 tumors with either long course neoadjuvant chemoradiation or short course radiation has led to a decrease in local recurrence in about 50%. But I'd like to dissect this a little bit further on focusing mainly on neoadjuvant radiotherapy in order to understand the components of total neoadjuvant therapy. So what are the data on randomized controlled trials from TMA with and without radiotherapy? The first trial, this was published in The Lancet in 2009 between Brits and Canadians, close to 1,500 patients with both stage 1 up to stage 3. It was randomized to short course radiotherapy or surgery alone, and patients who had a positive circumferential resection margin got selective post-op chemotherapy. In their 3-year local recurrence, there was a significant difference. If you look at the patients that had a negative circumferential resection margin, it was even more pronounced, and both of these are statistically significant. And if you look at the disease-free survival, it was also statistically significant, the difference between patients who got short-course neoadjuvant radiotherapy or TME alone. The Dutch trial that we all talk about, almost 2,000 patients. Important to know that there were stage 1 patients in this trial. Short course radiotherapy versus TME alone. 81% of the patients had a negative circumferential resection margin, and there's data showing up to 10-year follow-up nowadays for the local recurrence. No significant difference for stage 1 and 2, statistically significant difference for stage 3 patients. The overall survival was not significantly increased in the radiotherapy group, but one would think that over time this may be more pronounced and it could lead over time, but with 10 years of follow-up currently, there's no significant difference. If you look at the stage 3 patients that had a pathologically negative circumferential resection margin and were treated with TME alone, they had a 10-year overall survival of 40% versus 50% in the radiotherapy group, so that is something to consider, and that was statistically significant. What about imaging? There's 2 trials that I would just like to focus on. Everybody knows about the Mercury style from the UK. It's easy to do these kind of things when you have the best MRI reader and the best pathologist for rectal cancer in the world. 374 patients, but only 65 of those had stage 2 and 3. A lot of patients with very early rectal cancer. Only 19 patients received neoadjuvant chemoradiotherapy, long course, for a circumferential resection margin that was visualized on MRI of less than 1 millimeter. And pathology confirmed that a negative circumferential resection margin in 97%. This was a non-comparative study. I'll talk about it in a second. But their local recurrence rate, 3%, disease-free survival, overall survival, 85 and 68%. I don't know if that came up well, but what they have visualized that if you had a circumferential resection margin on the MRI of less than 1 millimeter, a distal rectal tumor, or the presence of extra mesorectal venous invasion, those were all predictors for increased local recurrence and decreased disease-free survival. Most recently, the OCUM study from Germany was published this year in the British Journal of Surgery. It was a prospective multicenter study, T2 to T4 tumors with any N status, obviously M0, almost 600 patients. Mid and low with less than 1 millimeter from the fascia, and all T3 and 4s received neoadjuvant chemoradiotherapy, which was about a third of those patients. All the other patients, including the upper rectum, or had more than 1 millimeter from the fascia, got TME alone. Their negative pathologic circumferential resection margin 97% versus 89% in those two groups. And the negative pathologic circumferential resection margin was predicted with MRI in 98%. So similar to the sensitivity and specificity from the Mercury study, but a larger patient. I think it was better designed, actually, than the Mercury study. They have a 60-month median follow-up, and that's what was published this year. 3 and 5 year local recurrence, no significant difference, and low, as you can see there. When they looked at 3 and 5 year distant metastases between the neoadjuvant and the TME alone, there was statistically significant differences, and you can see the percentages there. And for disease-free survival, you can see the differences there, both statistically significant. What I like about the graph on the right is that were patients that were planned to have surgery and they did not, and they received chemotherapy. As you can see, surgery after neoadjuvant. So there's two groups essentially, but there's groups that they recommended neoadjuvant therapy and the patients declined it and went straight to surgery. And that is what you're seeing, this bar of the local recurrence up on the top here, this solid bar that goes up to about 14% of patients that had a close margin that were recommended to have neoadjuvant chemotherapy and underwent surgery alone. You can see excuse me, the local recurrence as high as that. In their intention to treat analysis, there were also patients that they recommended TME first, and they preferred to do neoadjuvant chemotherapy. And that, when you look at the local recurrence, it's equivalent in the three groups that are on the bottom of this graph over here. So the take-home points from what I've discussed up to now is that pre-op imaging is key, specifically looking at the circumferential resection margin, which I think that MRI shows very well. That TME alone is associated with a higher local recurrence achievable with preoperative radiotherapy, especially in patients that are N1, N2. And there's really no randomized controlled trials comparing neoadjuvant chemoradiotherapy before surgery and comparing that to TME alone. So for me, the unanswered questions here is that what rate of an expected local recurrence is acceptable nowadays? It feels like we're looking for more and more, and the rates are lower and lower. Is there an imminence for overtreatment for these patients? How can we select patients better for receiving chemoradiation before surgery? Does the neoadjuvant paradigm delay systemic treatment? And specifically because we're seeing more and more patients with increasing rates of distant metastatic disease and not the local recurrences that we used to see. So why TNT? I think it was well studied in the 2004 German randomized controlled trial that there is a superiority of neoadjuvant chemoradiotherapy for patients with locally advanced rectal cancer. Neoadjuvant chemoradiotherapy followed by TME and adjuvant systemic therapy has been the standard in North America, but this is really not evidence-based, and I'm going to talk a little bit more about that. And I think there's factors associated with this. Mainly, there's low adherence to adjuvant therapy, the delays in therapy that is significantly associated with postoperative complications, and as I was discussing on the previous slide, there's increasing rates of distant metastatic disease in these patients, and it's not so much about the local recurrence anymore. So let's switch gears for 1 second and talk about adjuvant chemotherapy in rectal cancer. Not well studied. The evidence is very conflictive. There's not a good knowledge of the optimal timing of this. We can have a whole 15-minute talk about this, but there's essentially 3 studies that have looked at this. And if you look, and 2 of those, which is the DCCG study in 2015, the lower one, the ICNR study, no significant difference in 5 and 10-year disease-free survival in patients who received adjuvant chemotherapy for rectal cancer. We're going to look at the EORTC study specifically. It's the European study that looked at adjuvant chemotherapy for rectal cancer, over 1,000 patients, 10-year median follow-up. And as you can see here, the bars on the right, when they look at disease-free survival and overall survival, no significant differences between the patients who received adjuvant chemotherapy or not for rectal cancer. Specifically on this table, they have 4 columns here looking at patients who either received just radiotherapy versus chemoradiotherapy in the adjuvant setting versus adjuvant chemotherapy in those who had radiotherapy before or after surgery. I want you to focus on this one alone. So if somebody received radiotherapy alone with no adjuvant chemotherapy, there was an increase in metastatic disease at 5 and 10 years, as well as local relapse. But if you look at the other 3 columns, it does decrease over time. Probably the best group are the ones that got chemoradiation with adjuvant chemotherapy afterwards. But these 3 columns in general are not statistically significant different. It's mainly the patients who had radiotherapy and did not get any adjuvant chemotherapy after surgery. So that's where I think it was a main difference. If your patient is, and this rarely happens in the US nowadays, that if you're just getting radiotherapy before surgery, then you should probably get chemotherapy after surgery. And this is for patients with locally advanced rectal cancer. There's been a couple of other large database trials. This is from the NCDB, most recently from last year. Almost 13,000 patients, 32, so a third of patients received adjuvant chemotherapy. There is an increase in the trend during the duration of the study, as you can see there. 10-year follow-up. You can see we're in the kind of Midwest is in the lighter blue, which we're doing probably a better job than the rest of the country. They did, because probably of the power of the study, at least from a retrospective standpoint, there was a statistically significant difference in survival probability, as they calculated, in these patients who received chemotherapy versus no chemotherapy in the adjuvant setting. And this was significant for both stage 2 and stage 3 rectal cancers. If that's not alone, there's a Cochrane database that was published in 2012, 21 randomized controlled trials, over 16,000 patients, a significant reduction in the risk of death. This is group data. As I tell everybody, just because you take a lot of data that is not great and you put it together and it shows a significant difference, it doesn't mean that's great data. It's just take it for what it is. But they did see a significant difference in disease recurrence and risk of death in those patients who received adjuvant chemotherapy after TME. But they really didn't report on the TNM stage, toxicity from these patients, or completeness of therapy. So for those who are not TNTologists, as Dr. Madoff would say, consolidation chemotherapy refers to getting chemoradiation, and during that resting phase that can vary from anywhere from 6 to 12 weeks, we try to sneak a little bit of chemotherapy in there while we're waiting. That is consolidation chemotherapy. This was mainly initiated by Memorial Sloan Kettering, and this was the first trial reported, multi-center, phase 2, 259 patients, and they received a total of 50 grays of radiotherapy, and then they were divided into 4 groups. Radiotherapy with 5-FU, and they were divided in 4 groups. Some of them got none during that waiting phase. Some got 2 cycles, 4 cycles, and 6 cycles of FOLFOX during that resting phase. And then they would do TME in 6 to 8 weeks. And then at the end, even after TME, they were recommended to complete a total of 8 cycles regardless of how much they received before surgery. The median follow-up is not bad at all. Here we're just looking at the 4 groups and how much chemo they actually got. It's not prescriptive, but if you look at the patients, I'm just trying to get the mouse up here. So if you look at the patients that actually recommended 2, they're getting less than what they're really proposed. The patients that were recommended, for example, 6 cycles were getting less at all, and number of cycles here is 1.9. So in general, because of maybe toxicity or patient not tolerating things, who knows what, but patients were getting less than that was prescribed. When they looked at their pathologic complete response, I think the most impactful finding from this study was that 38% of patients in group 4 who were proposed to get 6 cycles of chemo after the chemoradiation had a significantly higher pathologic complete response. And on multivariate analysis, the only thing that really stood out was that the study group 1, those who did not receive any chemotherapy in that resting phase, had a significantly lower pathologic or complete clinical response. The nice thing about this study is they actually looked at toxicity. And here you can see the different grades of toxicity for the different groups, specifically looking at the group 4 that received a lot more chemotherapy before surgery. There was no statistically significant difference except for that grade 2 between 4 and 1, but not a lot or excessive amount of toxicity from giving chemotherapy before surgery as a consolidation strategy. When they looked at disease-free survival, again, for the YPT TNM stage, significantly different. Disease-free survival, looking at complete pathologic versus non-complete pathologic response. This makes total sense. We all know that. And if they looked at the groups alone, for those in the SG4, which got on average 5 to 6 cycles of chemo before surgery, their disease-free survival was significantly better as well. And this just shows in a larger graph that there was a significant difference in disease-free survival between the 4 groups of getting different dosages of consolidation chemo. The GRECCAR4 trial, French, European trial, that essentially had about 200 patients, and all patients received FOLFIRINOX for 4 doses, and then they were divided into 2 stratums, the favorable response, and some would go to immediate surgery versus getting chemoradiation, to the unfavorable response. They would get 50 grays versus an increased dose of radiation in the 4th group of 60 grays. Their primary outcome was R0 resection at 7 weeks. This was prematurely stopped because of low accrual, but we do have some data from this. When we look at the R0 resection rate, 100% in those first good responder stratum, whether they went straight to surgery or they got chemoradiation. For the patients that had poor response to chemotherapy, still an acceptable 82%. These were actually, if you really dissect the TNM stage, these were quite advanced tumors, and they received a lot of radiation, especially for that arm D, the 4th group. The rate of transformation from positive to negative, which was probably the most impactful thing for me reading this paper, was 93%, specifically in the patients that had bad tumors, bad biology, but got a lot of treatment up front. In general, TNT has been reported mainly by the Memorial Sloan Kettering group. This is not prospective data. 800 patients with T3, T4, N1 tumors. If you look here, they're about, in this, during the study phase, 811 patients, but we're focusing on these 410 patients where they recommended TNT. Of those patients, some received consolidation chemo, but they're not really reporting on this, but the majority of the patients received induction chemotherapy with a plan of either 7, 8, or more than 8 cycles of FOLFOX, and then either surgery or no surgery after that. There was a lot of significant differences, and this is probably because they're comparing the patients that had TNT with patients who had chemoradiation then adjuvant chemotherapy after surgery. But there were differences in age, obviously the period, the imaging sequencing that they were using on these patients going from ultrasound to MRI, stages, significant difference in the technique as well. So all this has to be taken into account when you interpret the results. When they looked at responses of therapy, specifically complete response, pathologic complete response for both, for patients that either received adjuvant chemotherapy versus TNT, you can see here pathologic complete response up to 53% in stage 2 and 32% in stage 3, significantly different than those who received their chemotherapy after surgery. This is something that I always put on a slide because, you know, people say, well, why are you doing this? It's, you know, it's not in the guidelines. Yes, it is. It was published last year for any T3 or N locally advanced rectal cancer as confirmed by MRI. You can read it yourself right there. So it's not something that we're just making up. What about the next step? So the next step, why are we giving everybody so much treatment? Are we over-treating a lot of people? Most likely, yes. How can we select, and like Scott was talking about yesterday, individualize people to a point where we can give chemotherapy and potentially operate on them, and forgetting about the whole watch and wait paradigm that Mark is going to expand on in a second, and just give them selective radiation or chemoradiation. Well, MSK has also published on this. It's a very early study, 32 patients, 6 cycles of FOLFOX. If they had stable or progressive disease, they got radiotherapy, but if they were responders, which usually is more than about 30% of response on MRI, they underwent TME and after about 3 to 6 weeks. The majority of patients completed the chemotherapy. All had tumor regression and TME without any preoperative chemoradiotherapy. They showed 25% complete pathologic response, and then you can see the 4-year local recurrence rate and disease-free survival. One of those patients did receive, all of them had R0 resections, by the way, and one patient did receive postoperative radiation, which, just as a parenthesis, unless there's very specific circumstances, I would highly recommend against. Everybody's waiting for the prospect trial. It's done. We're just waiting for it's cooking. So this is kind of the paradigm that we're looking at. If patients have response to FOLFOX and if they get chemoradiation, I guess our TME or TNT, arm is down here. So we'll hopefully have data on this soon, and that will show some light on if TNT is here to stay. So how can we better define, as has previously been discussed, the good, the bad, and the ugly? I think, again, individualize these strategies is going to be the way to go. You have to take into account tumor location, the biology of the tumor, all of the things that MRI gives you with regards to margin status and lymph node status, the response to neoadjuvant chemotherapy. These patients just can't be sent to the oncologist and come back and see me after about 12 weeks. I usually see them after they're done with at least about 4 or 5 cycles. They get re-scoped, they get re-MRI'd, because there are patients that progress on chemotherapy, and you want to identify those patients early, because those are the patients that may have to go to chemoradiation or maybe even to surgery earlier, and you can't just forget about them. I think we have to do a better job at discussing toxicity, because this can be a very big impediment in receiving the total neoadjuvant therapy or even delaying surgery or making surgery more complicated. So we can do a much better job on that. This is something I show all patients with rectal cancer so they know what their bowel function may be if they receive chemoradiation, and depending on where the location of the tumor is, I would highly recommend it to have in your clinic. So in summary, TNT is safe, has significant advantages. It assures treatment of lymphatic and micrometastatic disease, at least in theory. It improves tumor response for sure, and Mark will hopefully help us out a little bit more on are these patients going to get more of a watch and wait strategy. It improved disease-specific and overall survival in the 2 studies that have been published, and it does not appear to significantly increase short-term toxicity, at least, and post-operative complications. The other questions I'm going to leave you with is that, is there over-treatment? I think there is, and we can do a better job at selecting these patients, and we do not have any prospective comparative studies on this yet. Thank you.